Okay, good afternoon, ladies and gentlemen. Welcome to this session, lunchtime session, entitled Protect the Brain from TAVI. We'll discuss about stroke prevention during TAVI. And this session is supported by Boston Scientific. My name is Yohei Ono, interventional cardiologist, Tokai University Hospital. I'm delighted to be co-chaired with my great friend, Norio Tara from Sendai Kosei Hospital.
Hello.
We have the distinguished operators, interventionalists, Toru Naganuma from New Tokyo Hospital, Shinichi Kokura, Shirai, Kokura Memorial Hospital. Sorry about that. And Yusuke Watanabe from Tokyo University. So we will have three guest speakers, and we will learn about the SENTINEL system, Cerebral Protection System, and how it is used in US first, based on the clinical data. And we will introduce the early outcomes from Japanese data. And finally, we'll discuss about the randomized controlled trials so far based on this cerebral protection system. So just to begin with, who has already implanted Sentinel for stroke prevention during TAVI? Okay. The next question is, do you routinely use it or select it in selected cases? So who uses in routine case? Every case? Okay. Several? How about in selected case? Selected case. Okay. We will discuss this during the session. So first, we have a recorded talk from Dr. Kapadia from Cleveland Clinic. So we will appreciate this talk.
Thank you for the invitation to present at PCR Tokyo Valves. I'm excited to join you virtually. This is a talk on cerebral embolic protection using TAVR and what does the data support. This has been my interest for many years. I'm Samir Kapadia from Cleveland Clinic. I do not have any conflict of interest as listed here. If you look at the role of embolic protection in TAVR, there are several important things to keep in mind that I have tried to list here, and I'll go over this step by step. So the first question is that the stroke risk is there or stroke risk is trivial. If you ask many people, some of the investigators suggest that the stroke risk is trivial. It is not true. So in the partner 1B trial, it was 5%, 1A 4.7, and now it has come down. It has come down to maybe 2.5% if there is a neurological evaluation done in systematic way for the patients. So in the Sentinel trial, the control group, the stroke risk was 2.9%. And if you look at the TVT registry without CVP, it is about 1.4%. So this is the self-reported stroke risk from United States patients. This is half than what is seen if you have systematic neurological examination, because it is possible that you miss some minor strokes. Now, if you want to summarize the data of the CEP, we'll first start with the PROTECT-TAVI trial. Now, PROTECT-TAVI trial we conducted was in United States and outside of United States. So about 1,800 patients were enrolled from United States, 1,200 patients were enrolled outside of United States. And patients of all risk categories were allowed, all commercially available TAVR devices were allowed, and neurological exam was done in all patients pre-procedure, and then patients were either randomized to TAVR alone or TAVR with CEP, 1,500 patients in each group. Neuro exam at baseline, discharge in 72 hours. So if they are discharged before 72 hours, or if they are still in the hospital at 72 hours. And then it was performed by the neurology professional, and both the modified Rankin score, NIH, SS score, MOCA, and CAM ICU score were reported. Neurological exam was performed in all patients post-procedure. This is a little bit different than in the BHF TAVI protocol. And the primary endpoint was all stroke at 72 hours or at discharge. The primary endpoint is shown here, the stroke at 72 hours or at discharge. It was 2.9% in the control group and 2.3% in the CEP arm. Statistically, there was no difference. And if you look at a post hoc analysis or a secondary endpoint that we predefined, the disabling stroke was statistically significantly reduced from 1.3% to 0.5%. And there the p-value was pre-specified, but a secondary analysis. It was an important observation to say that the strokes, although major strokes were reduced, all strokes were statistically similar. In the PROTECT-TAVI study, we did the post hoc analysis to look at the US cohort and outside of US cohort. And as you can see in the 1,833 patients in the US cohort, both the all strokes and the disabling strokes were statistically significantly reduced. We published this in JAMA Cardiology. OUS cohort, however, did not see any difference in the stroke. And we tried to analyze this to try to understand that why there is a difference between the two groups, whether the valve use was different, whether the ACT was different. We could not identify the exact causes for these differences, but it was clear that in one population in the United States, there was a statistically significant reduction in all-cause strokes as well as in the disabling strokes. Now let us look at the BHF-TAVI protocol. BHF-TAVI protocol is very, very similar to the PROTECT-TAVI trial. Here, the patients were also enrolled who had a commercial TAVR in UK, and the with or without CEP device, 3,800 patients, twice the size of the PROTECT-TAVI trial. In the control group, there were 4,000 patients, CEP group 3,795 patients. Primary outcome was similar. Stroke definition was also similar. But one difference was that the neurological exam was performed in patients who had a questionnaire filled out which showed some differences from the baseline. So not a neurologist or a neuro exam was done in all patients, but patients who showed that there is a difference in their questionnaire were then further investigated. Another important difference compared to the PROTECT-TAVI, in the BHF-TAVI protocol, 81.2% of the patient had per protocol placement of both filters. In the similar number is about 96% in the PROTECT-TAVI protocol. The reasons for non-deployment included unsuitable anatomy, partially deployed one filter, or other various reasons as you see listed in this table. This is an important difference because in a device trial, when 1/5 of the patients are not getting a device, one question is if the device is possible to deploy or not, and the second question is that if the device is deployed, what would be the outcome of these patients. So if you look at the overall PROTECT-TAVI protocol, there was no difference in the strokes, 2.2 versus 2.1% in large patient population. We tried to do a combined analysis, a meta-analysis, individual patient data related, and this was pre-specified, pre-planned. So now from 3,000 patients in PROTECT-TAVI and 7,600 in BHF-TAVI, 10,000 total patients. And now we do intention to treat population, and we did the analysis with the same primary endpoint. If you look at this patient population, it is important to recognize that the average age was about 80, 38% were female. These are all high, intermediate, and low risk patients. And if you look at this, coronary artery disease is present in about 40%, prior revascularization 18%, prior stroke is about 6%. And now, if you look at the patients these 10,000 patients with the intention to treat analysis, the all strokes were no different, 2.3 versus 2.2. However, the disabling strokes showed some trend in the sense that it went from 1.3 to 1.0% with a p-value of 0.09. If you do the secondary analysis to say that is the CEP effective when we account for the non-adherence, meaning that if we say that we do the per protocol analysis. Now, it is important to recognize that when we do the per protocol analysis, it is possible that we breach the randomization, because now there are 877 patients excluded from the treatment arm, and that leads to only 4,410 patients, whereas in the control group, there are 5,253 patients. There is ways to adjust this kind of analysis, and it is different ways of statistically looking at it. But when we look at simple things to say that in a modified ITT, there was no difference, as I pointed out. But if you look at the per protocol analysis, the all strokes were reduced from 2.7 to 1.7%. So there's almost 25% reduction in the stroke per protocol. And if you look at the disabling stroke, again, there was a trend, but now the trend became statistically very significant from 1.3 to 0.8%. This is a very significant decrease in the disabling stroke that we saw per protocol. We said that there is no reduction in the periprocedural stroke with CEP in the modified intention to treat population, but in per protocol analysis suggests that strokes may be reduced with CEP when it is fully deployed according to the IFU. If you look at the role of emboli protection in the TVT registry, in other national databases, and single center data, you will find more information. In the TVT registry data, we looked at, with Dr. David Cohen, all the patients with two different ways of doing adjustment of the patients who got the CEP versus who did not get the CEP. And we found very similar information like a protected TAVR to say that disabling strokes seems to be reduced, and the disabling strokes were defined a little bit differently. The patients who had stroke who could not go home but had to go to a nursing home were defined as disabling strokes. And this kind of disabling strokes, or they died, this kind of disabling strokes happened more frequently in the non-CEP group compared to the CEP group from the TVT registry data. If you look at the other national registry, so this is the registry this is the Medicare database. Here we asked the question a little bit differently to say that if you have a stroke and if you did not have a CEP, what is your death rate? It was 11.8%. If you had a stroke and if you had a CEP, what is your death rate? 6.3%. How many times you will go home if you had a CEP with stroke? 28% time. 20% of times you will go home if you did not have the CEP device and if you had a stroke. In other words, the strokes were more significant, larger, if they did not have CEP device. Cleveland Clinic, we started using it in all patients from 2018 onwards. And as you can see, more than 90% of the patients, we are able to place the device. So this is also a little bit different than the BHF TAVI protocol. And these are unselected patients, all comers. And we try to analyze our data. And as you can see that people who were before the CEP use, we had out of 1,000 patients, 15 patients had stroke, 1.5% stroke rate. After the CEP device, 1,800 patients, 8 patients stroke, 0.4% stroke rate. So stroke rate is different. But more importantly, the 15 patients who developed stroke, 4 died, whereas 8 patients who developed stroke, nobody died. So this is a big difference in the outcome, meaning that the strokes are now smaller when you have a CEP device. If you look at the Cleveland Clinic data from 2018 till now, you can see that the stroke rate is 0.5%. So this is another very important thing to recognize, that out of 4,000 patients now that we are using CEP 90% of time with all commercial valves, stroke rate is 0.5%. There are several ongoing trials, and I'm not going to go into details of these trials. There are several devices being investigated, but it's difficult now to do these large-scale trials. So the large-scale trials are only available for the Sentinel device. All other devices are doing 300-400 patient trials currently. How do we interpret all this information? So this is now a very difficult question. Should we use CEP in the all TAVR patients routinely or not? Most people come and tell me that, listen, 2 trials are negative, we should not use it. So we have not done that because as I presented the data, if you look at the data with granularity, there is definite, that 2 things are definite. One is that the device can be placed very safely. And number 2 is that if the device is safely placed in the patient, there is decrease in the major strokes, and even the all strokes may be reduced. And at least in our experience in Cleveland Clinic, we feel that our stroke rate is so low with the use of routine CAP that we do not right now want to change our strategy of using emboli protection. There is a cost consideration, and some people are trying to say that we should come up with a score to say that which patients would be best to use the CP device. Bicuspid valve patients, valve-in-valve patients are some of the examples. But in a native TAVR, we have been having a hard time to find a very good predictive model to say which patient is going to have stroke. Stroke is very difficult to predict in regular TAVI patients. So we are still using it in all patients. I always say that the device trial interpretations are difficult because it is somewhat biased by the investigators' use. But at the same time, if the device is used properly, whether that really helps or not is an important question to be answered and should be investigated. So with that, I will end my presentation, and I'm happy to take any questions. Thank you again for inviting me to the Tokyo PCR.
Okay, thank you very much, Dr. Kapadia, for your comprehensive talk. So I think we can move on to the discussion. Please feel free to raise your hand or send your comment, questions, anything via the app, PCR app. So highly appreciated. Okay, so we had further information regarding those randomized control trials that showed the US data, outside of US data of the PROTECT-TAVI trial. And furthermore, for the British trial, patients who are appropriately implanted both distal and proximal filter seems to have a better outcome and lower stroke rates. So Yusuke, I think you are very familiar with the system, and you raised your hand to use it for the selected patients. So in your practice, what kind of patients do you aim to implant this device for stroke prevention?
Thank you. Okay, so I think it's not all patient is target of the implantation of the device. I think in my center we are choosing a patient with pre-or stroke. So that kind of patient has a stroke easily to have again. So that's a one criteria, and also the patient with a calcified valve. So much calcified valve should have a stroke in our experience. And also third one is the self-expanding valve. So self-expanding valve now the nature of the self-expanding valve is when cross the arch. So cross the arch is the devices don't have a function of the flex. So that kind of self-expand valve we routinely use CEP device.
Okay, so you mentioned about the degree of calcification. Do you have any specific cutoff, like calcium score or any kind of score, or just by looking at the CT image, you decide
looking at the CT image, we don't have so cut off, but also TAVI in sub procedure and TAVI in TAVI procedure we routinely use.
Oh, great. Shinichi, I would like to ask you the similar question because you also choose selected patients.
Yes, thank you very much. So in our institution, we use the Sentinel device for the selected patient. The definite using per patient is a TAV in TAV and TAV in SAV for the AES type valve degeneration and the previous history of a stroke. That is a good candidate for the Sentinel. And anatomically, so in balloon expandable valve, we didn't use the anatomical reason. But the self-expanding valve, we usually use the thickness of the, we have some criteria about the thickness of the aortic cartilage. So more than 3 millimeters thickness of the aortic cartilage plaque. So we actively use the Sentinel. Yes. Thank you very much.
Thank you. Next, I would like to ask Toru because I think you currently use for all patients. And we learned from that British trial that around 82% was met the criteria to implant both proximal and distal filters. I know in your best hands, the rate should be very high, but do you see any kind of cases that could be difficult placing one filter, let's say very calcified brachiocephalic artery or something like that? Or would you avoid those kind of anatomies beforehand by looking at the CT scan?
Thank you very much. Let me explain why we use routinely. Because last summer we had the case who suffered from symptomatic stroke. And the CT scan showed no heavy calcification of aortic valve, not much aortic atheroma. However, the patient suffered from a symptomatic stroke. After that, we changed our strategy to use this protection device for all cases unless CT scan shows contraindication anatomically. For your questions, if there is a severe toxicity, it's very difficult to deliver the Sentinel device into the aorta. For such cases, we may hesitate to use Sentinel device. But so far, we can deliver this device for all cases. But for one case, we required a Grandson wire from a standard Sion wire. But now, I believe we should not spend much time. I think better to keep less than 10 minutes for Sentinel placement.
Yeah, I totally agree. We also had similar stroke that was not completely predicted by the CT scan. No, the aortic character was very good. But although, unfortunately, that was a minor stroke, but it's very difficult to predict. Norio, I know everyone in the room knows that you love complex procedures. And we know that you enjoy doing like leaflet modification. So coming towards those even more complex procedures, getting a lot of redo cases, I think this device plays a role. So what is your feeling and what is your current practice?
Yeah, of course, the TAVI server, TAVI TAVR, and especially leaflet modifications such as Basilica Unicorn, we strongly recommend to use the CP device because there's I think the kind of the feel to have a higher instance of embolic.
Shinichi.
The other day, we experienced the Basilica procedures, and with using the cerebral embolic protection device. And then after retrieving the CEP device, burned tissue.
Burn.
Burn.
Burned.
We achieved
Burn.
as well.
Charcoal.
Yeah,
Charcoal.
Charcoal tissue
Yeah.
had been retrieved.
Yeah,
So,
yeah,
That's a problem.
and in leaflet modification, the cerebral embryonic protection is mandatory, I think.
Mandatory.
Yeah, the bottom line is that whenever we retrieve the filters, we more or less see some debris or any kind of tissue, right? So, okay, great discussion. So we'd like to move on, and I would like to introduce next speaker, Professor Kan Zen. He will give us a talk about the, I think, case-based and the early outcomes of Japanese data. Thank you.
Good afternoon, everyone and Chairman. I would like to show my presentation entitled Clinical Results of TAVR with Sentinel in our hospital. We use a Sentinel device for all consecutive patients who underwent TAVR at my hospital just after the Sentinel launch. The date is 20 January 2025, and to 13 November 2025, we collected over 213 cases. And among them, we couldn't use the Sentinel for several reasons. The knot passes, right subclavian arterial stenosis, and carotid arterial stenosis. And 6 patients were occluded for the transcarotid approach and valve-in-valve and no access site. And finally, in this study, the total cases reaches just 200. And among them, the 5 Sentinel incomplete opening cases were included. And we use the additional use of the other filter devices to protect the left subclavian artery together with Sentinel, the 5 cases. And we make the historical control for comparison. The left side bar means the historical cohort. And the period during the 2060 to 2025, the number reaches 1,250. And the yellow bar means acute cerebrovascular accident, and the yellow means non-disabling stroke within 72 hours. And the red shows the disabling stroke within 72 hours. And as you can see in this left picture, there is not any significant differences between the group, but regarding the disabling stroke, the incidence rate looks lower between the with and without Sentinel. And I also make the current cohort to eliminate the initial technical influence. And during the period was 2023 to 2025, and case number 496. And as you can see, even using this current cohort, the results look same, but regarding the disabling stroke, the occurrence ratio looks decrease with the Sentinel group. And among this cohort, 5 cases of the unsuccessful Sentinel opening are included. And among them, the 1 patient have a disabling stroke and 1 is a disabling stroke. After excluding these 5 cases, this cohort changed to this right picture, and acute CVA and non-disabling stroke also decrease, and as you can see, the disabling stroke patient become 0%. And when we compare the current cohort to this per protocol, what we call the per protocol cohorts, regarding the disabling stroke, we can see the statistical significance and the NLT number 45.2. And also between the two groups in the background, there is a significant difference about the age or clinical frailty scale over 5, diabetes and cerebral disease, and prior CVA and ejection fraction. So using these factors with this propensity score matching to these both groups, and we again investigated the comparison, and as you can see, even there is not any statistical significance, but in all of the stroke groups, we can see the trend of the decreasing the event. And also, we investigated the amount of the debris captured by the Sentinel. And we classified the amount of the debris from 0 to 3. The 0 means no visually captured debris, and the grade 1 means muddy or sandy debris, and 2 means membranous debris like this. And the massive debris are classified as a grade 3. And also we separate the cohort in the two groups, known or minor debris and the major debris like this. And surprisingly, we could get something debris inside the filter. In most of the cases, it reaches 91.5%. And in the major debris groups, the age was higher and the heart failure status were serious, and hypertension, the chronic kidney disease, and peripheral artery disease background are higher in the major debris group. And also, serum creatinine levels are higher in the eGFR, and ejection fraction value are decreased. Also, the calcium volume in the valve complex was higher in the major debris group. And in the major debris groups, sapien use ratio are lower, but evolute use are higher, but inhibitor use are lower, and there is a significant difference. And these factors are confirmed as a significant predictor of the amount of the large amount of the debris. But in our study, the hemodialysis and actual sickness factors not reach the significant difference, even it shows the trend. We want to summarize my presentation. The Sentinel is clearly effective for endoprotection in TAVR. Most of disabling stroke are originated from non-protected area, like a left bachelor artery or the incomplete filtering with Sentinel. And I think the good indication for Sentinel is that CKD and the PAD patient and the higher age or lower EF, self-expandable valve use, and the larger size of valve, and a large amount of calcium in annulus complex. Thank you for your attention.
So before we move on to the discussion, we're going to have a second presentation from the Dr. Yamamoto, please.
Wow, I'm surprised. Thank you. Anyway, thank you very much for inviting me. I want to talk about the stroke risk after TAVI, who should be protected. And here is my disclosure. So first of all, this morning session as a late-breaking clinical trial. Dr. Hiyoki presented the temporal trend of TAVI procedure in ocean registry. And the 30-day mortality of our TAVI program, and the 30-day mortality is excellent, keeping 1%, and recently the 30-day mortality is less than 1%. So that's TAVI procedure is very safe and established. However, it's very interesting. The rates of the stroke is still 2% around, never changed for 10 years. Okay, but the improvement with the development of the technical aspects or development of the technical improvements, the rates of the pacemaker implantation is drastically decreased, and the rates of the PVL is decreased. However, again, the rates of stroke is remained 2%. And here, this slide is a very, how can I say, confidential use case paper. Okay, so recently, we only focused on the very recent latest data, latest generation device. That means a Sapien 3 Ultra Resilient and Evolute FX and Navitar or Navitar Vision. That means a latest generation valve. We retrospectively analyzed more than 6,000 patients and focused on the latest generation devices and compared or investigated the incidence of stroke. Surprisingly, the new devices, low recapture rate and low frequency of the recapture or something in self-expandable design, but the stroke rate is 2.5 in hospital. So that never changed, unfortunately. And the impact of stroke, we can see there is a significant associated with the worse prognosis. Obviously, we experience it in our daily practice. Okay? So who should be protected? This picture is sent by Yusuke, the last year's local Japanese live transmission, and he got something, and he excited. I'm not sure this is associated with, he truly prevents the disabling stroke or not, but he seems happy. Okay, anyway, so who should be protected using the Sentinel device or cerebral protection device, I mean. So in deep dive into the very good analysis by Yusuke Watanabe, the risk factors of predicting stroke after TAVI, this data is only focused on the newer, latest generation devices. So that's Dr. Kan-sensei presented, as shown, is very similar. The balloon expander valve is lower than the other self-expand series, and also, interestingly, the supralinear design is the highest, and the interlinear design is a little bit lower. It's completely same, the single center result and multi-center results. I'm surprised. So we identify the 4 risk factors. One is self-expandable use, and number 2 is prior stroke. That's consistent with previous reports. And transfemoral access is protective, of course. And that means transfemoral access is a low rates of stroke, and higher EGFR, that means renal function. If the renal function is impaired, the risk of the stroke is elevated. Okay, that is the start line to discuss about who should be protected. And a simple risk model was created, and then, so very simple, very simple. If the patient undergoing TAVI using the self-expandable valve use, the stroke risk is 2 points calculated. And 1 point is a patient having a prior stroke or non-transfemoral approach or EGFR less than 45. Such kind of patient characteristics, we want to add the 1 point. And this risk score is gradually expanding. The risk score is increasing. The rates of the stroke also increasing. Okay. However, my question is, self-expandable valve is truly associated with the incidence of stroke after TAVI. What do you think? I think the stroke risk or selection bias in our daily practice. which device will you choose? Such kind of very heavy calcified and very, very within the left ventricular obstruction or calcium, such kind of cases. Probably many physicians prefer to use a self-expandable valve. So that the risk of the stroke should be determined on the patient background and the stroke risk itself or selection bias. These are very important points to consider who should be protected. And favor for self-expandable valve use, for example, this kind of patient, this is my first Navita case, okay? So, and also, many considerable or unpredictable, uncaptured risk factors, even using the registry data, RCT something. For example, this patient is obviously a pop-up case. The calcium score is more than 11,000, okay? 11,000 calcium score is very difficult to manage it, okay? So this is a very good summary in the Euro intervention for the how to manage the stroke prevention. For example, such kind of bicuspid anatomy is a risk, okay? And also aortic valve complex or calcified region, as Kan Sensei mentioned, okay, this one also. And LVOT calcification or THV design or BAV, pre-dilatation or post-dilatation something, and procedure time. These factors also associated with the risk of stroke. And we, unfortunately, ocean registry data didn't cover such kind of plaque morphology on the CT scanning. So these are, of course, related to the increased risk of stroke, I think, so that we need to cover. And beyond the procedure itself, the issue of heart, you know, the hypertonated leaflet thickening, sometimes associated with the risk of stroke beyond 2 days or 3 days something, and new onset of AF also considered. We need to consider it. So that, as the previous presenters mentioned, the stroke rates never changed. It's always 2% something. And during the procedure, of course, we can protect and prevent the stroke if we use the cerebral protection devices. But beyond the 1 day or 3 days, sometimes we find a new onset of atrial fibrillation or late terms on the heart, leaflet thickness. But we should pay attention for the oral anticoagulation should not be recommended when patient paroxysmal AF is documented. So no benefit of routine OAC use after TAVI according to the Galileo trial. So that is very complex. Anyway, so risk assessment and sentinel is how to prevent or how to use. It's very important. But according to the previous data and consensus data, the rates of the disabling stroke obviously decreased. So that now it's time to use a cerebral protection device. Thank you very much.
Thank you, Masa. So we're going to talk the discussion part. So Dr. Toru-san, so there is a kind of the data about major debris and the minor debris from Dr. Kan Sensei. So the major debris should, looks like so bad, as Yusuke said. Yusuke feels so, and calcium volume maybe one of the risk factor. So what do you think about the aortic valve, the calcification itself for the risk, or the selection for the CP device?
Thank you very much. Yeah, of course, if the patient shows a larger amount of calcification of aortic valve, it should be a risk of stroke. And according to our center's experience, in 1/3 of cases, we capture some calcification. And we send the specimen to a pathologic study, and they say, oh, it's a calcification by pathologist. So definitely heavy calcification is a risk factor of symptomatic stroke.
And from the Zensense's data, there's a new risk factor such as a bigger device. I've never heard that. Do you feel the same thing, Dr. Kokura-sensei?
Once more.
Shinichi Kokura, a bigger device is a risk factor.
Yes. And according to the bigger device, runs through to the aortic arch and inside the aorta. So maybe they scratch the aortic wall, and maybe it cause the stroke. I think, yes. But the bigger device is a risk for the high risk of stroke, I think.
Okay. And the Sentinel device should be inserted from the right radial or right brachial. So, Dr. Yusuke, there's any change of your system of the secondary access or atrial pressure approach or something?
Thank you. So in my center, monitoring of the aortic pressure, it's always done from it was right side, but we change to the left side or another using a big sheath from femoral to side port to major. And also some patient has a dialysis and right side of the that's right side. We cannot use right side. We performed 2 cases from left side. It was succeeded, and it's not off-label. It's off-label use, but we can do it. Yeah.
So, Dr. Naganuma, you tried almost all the cases. So, how about the dialysis patient?
We do not hesitate to make puncture from AV shunt side, even if it's the right side.
Right side.
For us, it's the same shunt PTA.
Shunt PT.
The same. Anyway, we make puncture.
How about Zen-sensei? Zen-sensei use almost all cases, and how about a dialysis patient?
I also want to use Sentinel for the hemodialysis patient, and as you said, that there is a limitation to puncture if the patient had a internal shunt on the right side, but sometimes we use distal radial puncture, or sometimes using the brachial access for use of the Sentinel.
Thank you. How about Ono-sensei?
We use the same style. We sometimes, most of the patients with dialysis patients also have a calcified radial artery, so it could be difficult even with a 6 French slender sheath. So we have to go from the brachial, but if the vessel allows, we have tried several cases going from the distal radial artery. But there was a little bit of a fight against the nephrologist.
So, do you have any question or suggestion?
I think Masa raised a very nice point that same trend with Zen-sensei's data, that self-expandable valves tends to have a high risk, but I think it's all about patient selection. Your beautiful Euro intervention summary suggests that highly calcified valve, longer procedure time, all favors the use of self-expandable valve. And patients who have highly calcified valve has a higher degree of atherosclerosis, so the vessel character is not optimal. So these things, I think, carries a risk for stroke. So I think it's reasonable to consider cerebral protection device using Sentinel in case of self-expandable platform cases. I apply this strategy as well.
And on the other hand, I believe some complex arch anatomy should be avoided because manipulation of the sentinel itself could be a risk of embolies. So I give up to use the device for such as some calcification on the brachiocephalic artery and atheroma on the outer curvature of the arch sometimes, but it also should be the benefit. So it's vice versa. So what do you think about it's a risk benefit?
Yeah, I
balance?
agree. So, Masa mentioned so longer time of the duration manipulation is not good for, and we should limit like 10 minutes to place sentinel.
So any good technique to use for the manipulation for the difficult arch anatomy? Do you think do you have any technique?
Yes. So hospital we can use the CT fusion images for the angiography. So so we can detect the root of the where is the first branch and where the second branch. So and some tips for the inserting the second branch. So if usually we implant the sentinel aerial view, but going to aerial view, the second branch is anteriorly running more than we expected. So, and hospital, most of the cases are using the CT fusion images. So it's very useful, but it's possible, yes.
So you use both of the LAO and the RAO?
Yes, LAO means is very good for the where is the second branch, but sometimes it's very difficult because so anterior. So we should the catheter clockwise, counterclockwise. So and if we think difficult to insert a second branch inside a wire. So we now going to the aerial view. So and checking the anteriorly or the counterclockwise or clockwise, and we can check the wire insertion for the second branch.
Nice. Do you have any comment, Masa-san?
He has a special technique to share.
No. Before talking about the special technique, I have an additional comment for the THV design impact of the stroke. And because I'm surprised the similar data of the single center Kyoto Prefecture and our ocean registry data, of course, we need to pay attention for the interpretation for the THV design differences on the stroke risk. But I think the intraannular design has no spine, but supraannular design have one single spine, so that is very high chance to go through the greater curvature line of the aortic root. So that is the reason why a little bit higher rates of the stroke rate. But of course, we need to pay attention for the THV design decision in patient undergoing TAVI is multi-factors. We should decide it. But in terms of stroke, we need to pay attention more, I think. So that, of course, because the multivariate analysis always consistent with increased risk of self-expandable valve. But it's not self-expandable valve is not unfavor for such population, but I think. And second one is very difficult to deploy the sentinel device itself is a risk of stroke, I think, because Zen-sensei has presented the failure cases causes a stroke. So that we pay attention for the very, how can I say, very tortuous lesion is also the risk of the stroke. We need to pay attention for that, I think.
Yeah, additional comment for Masa. So I think Sentinel device is nice, but we cannot cover also left side, left subclavian artery, and also the technical success is a little bit not so 100%. So I think the future device will be definitely needed, and please don't stop the new device making. For I want to ask
Boston.
companies,
Innovation.
innovation,
I want to ask Dr. Zen-sensei, because you use left subclavian artery protection for only 5 cases. So you find anything from this experience?
Yes, I have 5 cases experience use isonal field trap on the left subclavian artery to protect the left vertebral artery. That's the reason I started to use such kind of the manner is that even after the launching the Sentinel, the disabling and non-disabling cases show the posterior circulation near stroke, and that means maybe the embolization through the left vertebral artery and non-protected area. I said so. That's the reason why in the very high risk embolization high risk patient, I want to use isonal filter to protect every cerebral feeding artery. That's it.
So did you feel the additional benefit to protect the left subclavian artery for
Yes.
your experience?
And for all of the cases, there is not any embolization. And I want to show the case of the Tokyo block today, but I couldn't. But for all of the cases, just after the procedure, the next day we take the MRI images and see the diffusion images. There is not any infarction areas. So I believe that the Tokyo block protection promising for the very high risk of the embolic several embolization, like large amount of the shaggy specific plaque inside the, especially in the aortic arch, I think.
Thank you very much.
Yes.
So, and I use I use the second line, the pigtail line from the left radial, and I think the benefit of the left radial access is good to see the third takeoff of the left subclavian artery, and to choose the second, the left common carotid artery, it's very good to see, because there should be between the proximal sentinel filter and cut caster from the left radial artery. So they're very good to see.
That's right.
It's a kind of the similar idea of the Dr. Shirai sensei of the fusion CT, but it's very easy and good strategy. So it's my suggestions.
Deep-centrics.
Yeah.
Okay, so I think we are about time to close the session. Is there any additional comments or questions from the audience? Okay, so I think we learned a lot. I enjoyed the discussion, and I hope you enjoyed a lot. So to summarize, we learned a lot from the US colleagues, the current usage of the cerebral protection device based on the randomized controlled trials, and he provided another further deep analysis. And I think the bottom line was to select the right patient. And if we success to implant both filters appropriately, there are high chance of reducing stroke, especially the disabling stroke. And that's, I guess, a strong message. And from our Japanese colleagues, beautiful data set, And we were able to identify some of the predictors of the stroke prevention. So we also have a nice scoring system, Yusuke. And so we will be able to select patient even better from next week for our patients. So thank you so much for joining, and thank you so much for the Boston Scientific for supporting this session. Please enjoy the rest of the course.